Good afternoon, everyone. I'm happy that you have come out to listen to my talk. And my name is Phillip Harter. I am a senior studying political science. And my project today is one that I worked on in the summer of 2019 under the tutelage of Dr. Robert Hayashi of Washington University School of Medicine. And it looks to investigate the influence of schedules and infusion times on cisplatin-induced toxicity in pediatric patients. So a little background and our working hypothesis on this. Cisplatin is a platinum-based chemotherapy agent with known ototoxicity and nephrotoxicity. So toxicity of the ears and toxicity of the kidneys. Renal toxicity for cisplatin is a result of uptake and activation of platinum in the kidney itself. But the cisplatin-induced ototoxicity, that's still up for debate. People think it could be due to reactive oxygen species or due to the nitric oxide which would have a direct cytotoxic effect, which people are commonly cited as the reason. And when I talk about scheduling times and infusion and schedules, so schedules in this study is the number of days. So you can get cisplatin treatment for 1 day, 2 days, multiple days. And time is how long the infusion lasts. So the infusion can last 60 minutes per session. It can last 120 minutes per session, 240 minutes per session. Each one's different. And at the time, as the study progresses forward, as it continually does, as we continue to get more data, there's been a dispute in the literature about what infusion schedule and what infusion time results in the greatest toxicity outcomes for patients. There was a study in 2001 that suggested that short bolus infusions had greater toxicity compared to 3-hour infusions of 40 milligrams per meter squared of cisplatin. And 1 hour's infusions were concluded to not be safe. But in 2019, another study compared 1 hour to 3-hour infusions and saw no significant impact on GFR, which is used for renal function. So there's a dispute in the literature about what type of infusion is best. In our study, we hypothesized that the longer continuous infusion would result in greater toxicity because you would be experiencing a longer exposure to these toxic medications that are chemotherapy. As you can see in the curve I have here, this longer one, the area under the curve of the continuous infusion compared to the bolus infusion has more exposure to the potential of toxic side effects. So for this experiment, we had to examine a lot of different variables. We went through a large patient pool, about 76 patients, and each patient would have multiple cycles. So we had about 282 cycles of cisplatin. And those cycles ranged from 60-minute infusions. Some 60 minutes were 5 days, 4 days, 2 days. We had 240-minute infusions, which were 1 day or 2 days. We had a 360-minute infusion schedule that was 1 day a week. And we had some 400. When I say we had just one, I don't mean one patient only. There were sometimes multiple, but instances of infusion schedules and times. We had 480 minutes of infusion for 1 day. I also examined other risk factors that were associated with the use of these chemotherapy agents, cisplatin. Chloride levels, potassium levels, sodium levels, magnesium, hemoglobin, white count, platelets, age, race, the specific cancer they had, the interruptions in infusion. So sometimes when you're having a longer infusion, you have to pause the infusion to put an IV in or something else that's going on. Look at the rate of infusion, so how fast the medication was actually being transmitted to a patient. And afterwards, you use IVs to flush the cisplatin. So we looked at the IV and IVF rate after the infusion as another potential variable that could be conflicting the results. And for renal toxicity, I examined the change in serum creatinine. Creatinine is a chemical waste product of muscle metabolism. So if it usually indicates a higher level will indicate less renal function because the kidney will be able to clear creatinine, but an inefficient kidney and a damaged kidney, the creatinine levels will go up and up and up and up. So a higher change of creatinine would suggest a greater change in kidney function. And we looked at not a wide range. We didn't look at every single type of cancer. We looked at neuroblastoma, brain tumors, which consisted of medulloblastoma and pineoblastoma. We looked at osteosarcoma hepatoblastoma, and germ cell tumors in pediatric patients only. And for pediatric patients, we define that from 2 months to 20 years. What you have here is the list of all of our patient data, and our average age was 7.9. And what I would do is I would go into Epic. I would look in Epic is the system of patient database, and I would document all of their information that we could have. So we have you can see here that we have a wide range of tumors represented, wide range of cancers represented. We have different genders represented. We have different races represented. And the sample consisted of 76 patients total with various tumors and cancers and genders being present. So the results were interesting, and with 76 patients, we are still tabulating more results. We're adding more patients as the study continues to go, but this is our initial preliminary results that we have as we continue to gather more patient data and expand our interpretation. This is our results as of our 76 patient mark, which we believe to be enough to draw upon some statistical significant results. And what we found was that the disease ranked by mean percentage creatinine increase. We found that the neuroblastomas were the highest, and then others, which were a couple other tumors that we included in our sample, but there were few of those to be included. And what you'll notice is that the p variable, which is a statistically significant variable to look out for. We had 3 that were considered statistically significant, and that was the diagnosis, so which tumor would result in most creatinine increase. So we saw neuroblastoma was the highest that would have the greatest change in creatinine increase, and that was statistically significant. We also saw magnesium and chloride levels significantly impacted by the use of cisplatin agents. And the typical treatment that we saw for neuroblastoma, after looking at every patient that kind of had neuroblastoma, because if you look back, we had 12 patients that were treated with neuroblastoma. Of those 12 patients, almost every single one of them had 60 minutes, 4 days cycles for cisplatin. And what was significant for those was the resulting creatinine increase. And if you examine here, you'll see the percentage change in creatinine compared to the infusion time. And so what you'll see is a cluster, a slight decrease, though not too significant, though not too clinically significant. You'll see that around 240 minutes was where we see a significant growth of the percentage creatinine increase based on the number of patients available for each study that we had. And so if we break it down to just the minutes themselves, before we look at the days, there are 2 things that are important to notice. There is the mean average of change in creatinine increase and the standard deviation, because the standard deviation will tell you how many of these cases were all over the place based on the numbers that they had. And so what you'll notice is that for the lowest mean average of creatinine percentage increase and standard deviation, that the 240 minutes was the lowest of them. So you'll notice that the 240 minutes was the best for resulting toxicity and percentage change in creatinine, while the 480 minutes, which was the long continuous cycle, had the worst. It had the highest mean and it had the greatest standard deviation, meaning the toxicity from that was most likely going to be all over the place. And that's something you don't want when you have patients. What you want is to have a controlled environment and a controlled idea of what the resulting toxicity will be once you get cisplatin treatments. And then we did the same kind of analysis for the days, so that we could figure out which day cycle would have the greatest toxicity impact. And what we found is that the greatest cluster around the mean, around 0, was the second day, I believe. Yes, just confirming my results. The second day had the lowest mean, and it also had a fairly low standard deviation, though not in this case, but in comparison to the mean that was presented for 4 days, which is the second best, the 2 days was the best option for the amount of days you would have an infusion of cisplatin, while the worst was the 1 day, which are typically used with those longer continuous cycles, like the 480 minutes, which we saw was the worst infusion cycle for resulting renal toxicity of a pediatric patient. So what you want to avoid is based on our initial data and our initial results of the study, you want to see for renal toxicity in pediatric patients, you want to avoid those longer continuous cisplatin infusion cycles. That would be usually typically 1 day for 480 minutes or perhaps 360 minutes. Those are the ones that we would see that you would want to avoid. And on the other side, you would want to, what we found was that 2 days, 240, tended to limit the amount of standard deviation that was present. So from patient to patient, from cycle to cycle, our analysis was based on cycle. So from cycle to cycle, there was less deviation in the resulting toxicity for the 2 days, and the second least deviation for the 2 days, and the lowest deviation for the 240 minutes infusions. So combining the two results, we can see that the 2 days, 240 infusion cycle resulted in the least renal toxicity. And as I said earlier, the 360 to 400 minutes, 1 day's infusions are generally more toxic for pediatric patients, and generally less cumulative doses when compared to 60 minutes, 4 days, and 5 days infusion rates, that the 2 day, 240 infusions were less toxic than those kind of cycles. So we are going to continue to expand our sample size, but at this time, our data is strong enough to suggest that there is a correlation between these general cycles and the resulting renal toxicity. Now, one part of our analysis that is going to continue to go is we're going to be focusing on actionable variables, so potential ways to modify future practices to reduce renal toxicity and ototoxicity. And you might have noticed that I didn't bring up ototoxicity as much. Well, that's because the analysis of the ototoxicity is still recording the hearing loss. Since we're using pediatric patients, it's much more difficult to get that data over time, and this is a clinical study. So we are still collecting that data as it goes and as the children grow, because you have to follow ototoxicity as a patient ages. And so we are going to continue to collect the results on ototoxicity as we move forward. And we're going to continue to grow our sample that we have to see what other findings we may be able to come up with regarding resulting toxicity due to cisplatin infusion rates and schedules. And a special thank you today. I'd like to thank Dr. Robert Hayashi, most importantly, because he was my mentor throughout this project. Dr. Stacy Snyder was the resident who I worked with on the Clintonil project. Kara Sahlberger, Ning Yang Wu, Rachel Sorozan, who was the founder of the program that I did this, well, not the founder, but the administrator of the program that I did this through, and the Siteman Cancer Center and the Lee Menhouse Springer Summers Opportunity Program that was giving me the opportunity to do this research, and Washington University School of Medicine and Children's Hospital. And I'd like to thank you for listening to my presentation, and I hope that you all have a really good day.